Welcome to This Week in Pulmonary and Critical Care Medicine. If you're practicing in the ICU or clinic, this week's literature speaks directly to three questions we all face regularly. First, should we be routinely prescribing cardioselective beta blockers in patients with COPD to reduce cardiovascular events? Second, does targeting serum albumin above 3.0 grams per deciliter in septic shock actually improve survival? And third, the 2026 AHA-ACC Acute Pulmonary Embolism Guideline introduces a new clinical classification system that may change how we risk stratify and manage PE from the emergency department through follow-up. These are high-impact topics. They influence day-to-day decision-making. Let's start with COPD and beta blockers. Patients with COPD carry a high burden of cardiovascular disease. In moderate disease, cardiac mortality can rival or exceed respiratory mortality. Observational data have long suggested that beta blockers might reduce both exacerbations and death, yet clinicians remain cautious because of concerns about bronchospasm. The PACE trial was designed to address this directly. It was a multi-center, double-blind, randomized Phase 3 trial conducted across 22 sites in Australia, India, New Zealand, and Sri Lanka. Participants were between 40 and 85 years old, had post-bronchodilator FEV1 between 30 and 70% predicted, and at least one COPD exacerbation in the prior 2 years. These were not mild patients. The mean FEV1 at baseline was 45% predicted. A total of 280 patients were randomized. 143 received Bisoprolol at doses between 1.25 and 5 milligrams daily, and 137 received placebo. The mean age was 68 years, and 83% of participants were male. Rather than selecting a single primary endpoint, the investigators used a hierarchical win ratio composite. Death was prioritized first, followed by cardiac or respiratory hospitalizations, exacerbations, quality of life measures, and FEV1. Across 6,763 pairwise comparisons, Bisoprolol was favored in 45% of comparisons and placebo in 48%, with 7% tied. The resulting win ratio was 0.95, with a 95% confidence interval of 0.72 to 1.25. and a p-value of 0.72. The net benefit was minus 2%, with a confidence interval ranging from minus 15 to 10%. There were no statistically significant differences in all-cause mortality, cardiorespiratory hospitalizations, major adverse cardiac events, moderate or severe COPD exacerbations, lung function, symptoms, or quality of life. 15 patients in the Bisoprolol group died, representing 10%, compared with 11 patients, or 8%, in the placebo group. None of these deaths were attributed to the study drug. COPD exacerbations occurred in 58% of the Bisoprolol group and 64% of the placebo group. The interpretation is careful and important. Bisoprolol did not improve overall cardiorespiratory health in this moderately severe COPD population. At the same time, it did not produce harm. That nuance matters. Earlier trials with less selective beta blockers raised safety concerns. Here, a cardioselective beta-1 blocker did not worsen outcomes. The broader lesson is that beta blockers should not be used in COPD solely to reduce exacerbations or mortality in the absence of a cardiovascular indication. But if a patient with COPD clearly needs a beta blocker for heart failure or ischemic heart disease, this trial provides reassurance that Bisoprolol appears safe in this setting. Albumin is not simply a volume expander. It carries endogenous molecules, binds inflammatory mediators, modulates nitric oxide metabolism, and contributes to oncotic balance. These properties have fueled decades of debate about whether albumin should be used routinely in septic shock. The ARIS trial addressed a focused question. Does maintaining a serum albumin concentration of at least 3.0 grams per deciliter improve survival in septic shock? This was a multi-center, open-label, randomized clinical trial conducted in 23 ICUs in Germany. Patients were enrolled within 24 hours of septic shock onset. In total, 440 patients were randomized, with 222 assigned to albumin and 218 to standard crystalloid therapy. The median age was 69 years, and approximately 2/3 were male. Patients in the intervention group received 20% albumin to maintain serum albumin at or above 3.0 grams per deciliter for up to 28 days during their ICU stay. The primary endpoint was 90-day mortality. 90-day mortality was 43.3% in the albumin group, with 91 deaths among 210 evaluable patients, compared with 45.9% in the control group, with 96 deaths among 209 patients. The relative risk was 0.94, with a 95% confidence interval of 0.76 to 1.17, and the p-value was 0.71. There were no significant differences in 28-day mortality, 60-day mortality, ICU mortality, in-hospital mortality, organ dysfunction, fluid balance, ICU length of stay, or hospital length of stay. The study was terminated early because of low enrollment, which limits power and leaves wide confidence intervals. Albumin administration was safe. It did not improve survival. The confidence interval does not exclude a small benefit or a small harm. This pattern feels familiar. The SAFE trial and Albios raise similar signals without definitive mortality reduction. Septic shock is not primarily a state of albumin deficiency. It is a syndrome of inflammatory dysregulation, endothelial dysfunction, and microcirculatory failure. Correcting serum albumin corrects a number. It does not necessarily reverse the underlying pathobiology. Albumin remains reasonable in selected circumstances, but routine albumin replacement to a numeric threshold does not appear to modify survival in septic shock. Let's slow down here. Pulmonary embolism is not a clot problem first. It is a right ventricular problem first. Clot burden matters only because of what it does to the pulmonary circulation and, in turn, to the right ventricle. The 2026 ACC Guideline reframes acute PE around that physiology. Instead of labeling patients as massive or submassive, it introduces 5 acute pulmonary embolism clinical categories, A through E, that reflect the continuum of right ventricular stress and failure. To understand why this is an improvement, think through the sequence. A clot suddenly increases pulmonary vascular resistance. The right ventricle, which is thin-walled and designed for low-pressure circulation, now faces acute afterload. Unlike the left ventricle, it does not tolerate abrupt pressure increases well. Initially, the RV compensates. It increases contractility. Heart rate rises. Stroke volume may hold. As resistance increases further, the RV dilates. That dilation stretches myocardial fibers and increases wall tension. Oxygen demand rises while coronary perfusion pressure falls. Ischemia can develop even without coronary disease. When the RV dilates enough, the interventricular septum shifts leftward. This impairs LV filling. Cardiac output drops not because the left ventricle is weak, but because it is underfilled. That is the moment when PE transitions from a respiratory disease to a hemodynamic disease. The new clinical categories reflect where the patient sits along that trajectory. Category A includes patients with incidentally discovered PE who are asymptomatic. There is no hemodynamic compromise, no RV strain. These patients can be discharged from the emergency department. That is a meaningful shift. Not every PE requires admission. Category B includes symptomatic patients but with low clinical severity scores. Their RV is coping. Biomarkers are not elevated. Blood pressure is stable. The guideline generally supports early discharge for these patients as well, assuming safe outpatient follow-up. Category C is where things become more nuanced. These patients are symptomatic and have either elevated clinical severity scores, elevated cardiac biomarkers such as BNP or troponin, or evidence of right ventricular dysfunction on imaging. This is compensated RV strain. They are not hypotensive, but the RV is under stress. These patients should be hospitalized for monitoring because the trajectory can change. Category D represents incipient cardiopulmonary failure. Here, the RV is struggling. Blood pressure may be marginal. Oxygenation may be worsening. The system is unstable but not yet collapsed. Category E represents cardiopulmonary failure with persistent hypotension. This is true hemodynamic compromise. At this stage, cardiac output is insufficient and end organ perfusion is threatened. This staging matters because therapies have risks. Systemic thrombolysis can reduce clot burden quickly, but it carries bleeding risk, including intracranial hemorrhage. Catheter-directed therapies aim to balance clot reduction with lower systemic bleeding risk. Mechanical thrombectomy removes clot without thrombolytics, but requires expertise and infrastructure. The guideline recommends advanced therapies as reasonable in Category E1 and potentially considered in certain Category D subgroups. The key principle is proportionality. The sicker the RV, the more justified the risk of escalation. Another important shift is the integration of multiple data streams for risk stratification. The guideline emphasizes that no single parameter should drive decisions. Clinical severity scores such as PESI, hemodynamics, biomarkers, right ventricular imaging, and even thrombus burden should be interpreted together. Right ventricular dysfunction alone is not equivalent to impending collapse. Many patients with RV dilation remain stable. What matters is trajectory. Is the RV adapting or is it failing? The guideline also highlights early disposition decisions. Asymptomatic patients and low-risk symptomatic patients can often avoid prolonged hospitalization. This reduces unnecessary resource use and potential hospital-associated harm. On anticoagulation, the recommendations are clear and pragmatic. Low molecular weight heparin is preferred over unfractionated heparin when parenteral therapy is required because of more predictable pharmacokinetics and lower risk of heparin-induced thrombocytopenia. Direct oral anticoagulants are recommended over vitamin K antagonists in eligible patients because they reduce recurrent venous thromboembolism and major bleeding risk. Extended anticoagulation beyond 3 to 6 months is recommended for patients without a major reversible risk factor or with persistent risk factors. This reflects recurrence risk rather than acute physiology. Finally, the guideline stresses longitudinal follow-up. Patients should be asked about persistent dyspnea and functional limitation at every visit for at least 1 year. Chronic thromboembolic pulmonary disease is not rare, and delayed recognition leads to missed treatment opportunities. So what is the larger educational takeaway? Acute PE management should be guided by right ventricular physiology. Risk stratification is dynamic. Escalation should be proportional. Disposition decisions should reflect true risk, not habit. This guideline moves PE care towards structured, physiology-driven decision-making, and that is progress. This week's studies remind us that not every biologically plausible intervention translates into improved survival. Bisoprolol in COPD was neutral but reassuring for safety. Albumin in septic shock was neutral despite physiologic appeal. Acute PE management evolves not through dramatic breakthroughs, but through structured refinement of risk assessment and escalation. Evidence forces discipline. Discipline improves care. If this discussion was helpful, subscribe to stay current with the most relevant pulmonary and critical care literature each week. Until next time, practice deliberately.